Bismillahirrahmanirrahim. Dear colleagues, hope you are enjoying with the course of Neurology. The subjects we are going to discuss now is multiple sclerosis. In this lecture, we will explain in details everything about multiple sclerosis or MS. What is the MS? What are the common causes and theories of pathology of MS? What are the common symptoms and signs of MS? How to ensure the diagnosis of MS, that this patient having MS, and what are the needed investigations to confirm this diagnosis? According to what we can describe or design the plan of treatment, and what are the services liable and available for this patient. What is the MS? MS is defined as multiple patchy degeneration of the white matter of the CNS. That means post-inflammatory demyelination of the brain and the spinal cord. This figure explains the central nervous system, brain and the spinal cord. Inside the brain there is interneurons, and spinal cord carried the ascending tract that carried impulses from the periphery up to the spinal cord, and descending tracts that carries signals from high centers to down to the spinal cord, then to the periphery. This tract is liable for destruction of coverage sheet. This is the normal axon. The normal axon is wrapped with myelin sheet. In MS, there is inflammation occurred to this myelin sheath, result in its destruction, which affect the conduction of impulses that pass along this nerve. This figure shows the central nervous system, brain and spinal cord, and the out nerves from the spinal cord. Central nervous system is connected with the peripheral nervous system, so the different parts of the body will be affected with the degeneration of central nervous system. The common areas shown to be affected by MS is brain, brainstem, spinal cord, and cranial nerves in the brainstem, and optic nerve in the high spine, in the high origin or nucleus of the brain, which is common cranial nerve affected post demyelination. This disorder characterized by special criteria. It is occur in young age, which is the age of high immunity, maybe from 20 to 45, or from 25 to 40 or 50. Female is liable for affection more than male, with the ratio is 2 to 1. Most of these patients suffering from bladder disturbance, about 80% of patients. This criteria help us in ensuring the diagnosis. Authors put about 3 theories about the causes of MS. They mentioned that may be due to genetic factor or environmental factor, as post-viral infection, or due to mainly autoimmune disturbance. Autoimmune disturbance attacks occur post-inflammatory reaction to CNS, result in loss of myelin sheath. Sometimes the disease is progressive, result in loss of the axons. This demyelination disturbing the conduction velocities of signals along this affected nerve, result in maybe affect tracts like pyramidal tract, result in spastic paralysis, or maybe affect nerves like optic nerve, result in blindness, maybe affect interneurons or tracts within the cerebellum, result in ataxic manifestation. All of these factors may be results from autoimmune disturbance. Here, the normal structure of the neuron. As you know well, neuron is the unit of the nervous system. Collection of neurons form nerve. Collection of nerves form tracts. So, this nerve formed from nerve cell and axon. This axon covered with myelin sheath. And along myelin sheath, the signal transmitted to electricity and can transmitted along the nerve to reach the other nerve or the effector, whatever, somatic to the muscles or autonomic to organs. In cases of autoimmune disturbance, as we see, autoimmune cells pass around the nerve peacefully without any problems. When inflammatory reaction occurs to the nerve, result in destruction of the sheath. Due to disturbance of autoimmune system, the cells of autoimmune system will destruct the nerve instead of destruction of the virus. بمعنى ان يفقد اللغة او اللينك between السيلز of autoimmune system والاكسونز of the nerve. هيحصل ان السيلز هتهاجم النجد او الاكسبوزد نيرف لانها بتعتبره غريب او foreign body زيه زي الفيروس، وبالتالي يحصل exaggeration of symptoms. الحقيقة أهمية MS دراسته في بلادنا العربية جت من تصنيف WHO World Health Organization لترتيب MS على مستوى العالم. فجي ترتيب الأرابيك population نمبر 4، وده معناه ان احنا في وضع متقدم جدا. وكان ناتج عن الكلاسيفيكيشنز ده ان انشأت الجمعية المصرية للتصلب المتعدد او MS Egyptian MS Society، ومقرها في القصر العيني، وهي على صلة دائمة بالانترناشونال سوسايتي اوف MS سواء من حيث الابحاث او تبادل الحالات عن طريق الفيديو كونفرنس. How to make and confirm diagnosis of the patient. When the patient come to us with motor or sensory or cranial nerve examination, cranial nerve problems, we must ask about the history of these neurological attacks. Ask the patient about any previous attack, whatever this attack, motor, sensory, or related to the cranial nerves. These attacks and affection may be separated and different. مش شرط ان البيشنت يجي يقول لي انا حصل لي قبل كده باراليسيس. البيشنت ممكن يجي يشتكي من باراليسيس at this session، لكن أنا لو asked about any affection of vision from 1 year, from 1 month, from in the previous time, he will say yes. This means recurrence or relapse or repeated attack. Another sign which make sure that the MS, beside the different attack of neurological signs separated in space and time, is the presence of unexplained urinary tract symptoms, as we will discuss later. The symptoms of MS different according to duration and severity of the attack. The onset of the disease different from other diseases of central nervous system. Not sudden attack or gradual attack. It is called relapse remitting attack or remission and exacerbation. It may be progressive in some cases. Relapse means development of new symptoms rather than that occurred before. It may be lasting for more than 24 hours, may be followed by the period of stability, or disability may be continued according to the severity of the case. Acute relapse may be occur. The precipitating factor or factors that may aggravate the symptoms and result in acute attack may be from fatigue, whatever this fatigue, physically or mentally fatigue. Heat increase the attack and the symptoms. Post-pregnancy and labor may be a precipitating factor. Intervention for relapses causes functional problem, which is important for us as a physical therapist. These lines explain the different courses of the MS. According to the color follows us, the first color is the blue color. This means this is the time and this is the disability. This means the attack occurred early in life and progressively increased in its disability. This means the patient not relieved by any treatment. The interrupted black line means the attack occurred early and result in plateau. What is the meaning of this plateau? The attack result in special symptoms and signs, and these signs not progressed or regressed. It is still as it is. The third course is represented by a red line. The patient spent part of his life free, normally, and healthy. The attack occurred greatly, high attack, and reached to the peak. After certain time, by treatment, the signs and the symptoms declined to reach to the normal level as before the attack, and the patient spent part of his life freely and healthy. When he exposed to any factor that aggravate the signs and symptoms again, the attack occurred again, but this time it is less than the first attack in the time and in the disability. After treatment, he will regain again to his normal life. The last course represented by Brown. The patient of the attack occurred and responds to treatment for time. Then anything occur, any factor occur, increase the attack, by treatment regained again, but not to the healthy time, regained again to the level of the first attack, and spent part of his time. Another attack will occur, but is less and minute in severity and time in relation to the first attack. To the second attack. Then this is the first attack, second attack, third attack, fourth attack will be occur and increase progressively to high disability. This figure represents the different forms of courses that may occur to the MS. Maybe along his life, the patient faces 3 attacks, but with progressive disability. Maybe the attacks minute. Maybe the attack occur with plateau. Maybe progressively increased. Maybe liable the patient faces more than 2 or 3 attacks. This is the common forms of or subtypes of MS: relapsing and remitting. First attack, the second attack occur more than the first. Third, fourth attack occur without timing between them, and this is called relapsing remitting attack. Secondary progressive attack, we can observe that the attacks occur with increasing in disability, and this is called secondary progressive course or type. The primary progressive, which is the most worst type, from the beginning the attack occurs progressively until reached to the respiratory system, leading to death. Progressive relapsing means the attack occurs with remission and exacerbation. The investigation needed for the neurologist: MRI helpful in detecting the patches in the brain, visual effect responses for the optic nerves, lumbar puncture for examination of cerebrospinal fluid CSF. This is the healthy brain. This is the patches or plaques that represent the patches degeneration of the white matter of the brain. So, diagnosis is based on neurological examination, MRI, and symptoms and common health problems. As we know from the nature of affection, and this demyelination may affect any tracts, any areas of the brain or the spinal cord, so it can be affect one or more of the following symptoms. So the patient may be suffer from 1, 2, 3 or all of these symptoms. Patient may be suffer in one attack with one of these symptoms or more, and the second attack may be suffer with the same symptoms or other symptoms, most commonly suffering from another symptoms. So periodical assessment is very important. Reassessment of the patient is very important, even during the same attack. Vision may be affected, which is occurred with high percentage. Sensation disturbance or sensory disturbance in the form of numbness, tingling, burning, pain can be occurred, or sense of pain during the attack due to spasticity, or after the attack due to residual effect of spasticity. Motor affection may be appear in the affection of muscle tone, hypertonicity or muscle spasm, or hypotonicity may be occur. Muscle weakness may be occur as a result of disuse. Balance disturbance and disequilibrium with high risk of falls can be result. Vertigo may be result in disequilibrium and disturbance of balance with autonomic manifestations like feeling of nausea, vomiting, blurring of vision, and feeling of instability. Speech disorders or the speech problem may be results or appear in the form of slurred speech, dysarthria, swallowing disturbance, and dysphagia results from difficulty of swallowing as a result of affection of certain cranial nerves. Fatigue is a factor and the sign important should be put in consideration during assessment and the treatment of this patient. Bladder disturbance with its variety of disturbance, as we will mention ataxic manifestations may appear in the patient, whatever the type of ataxia. May be sensory ataxia due to lesion of posterior colons, may be vestibular ataxia due to affection of semicircular canal, or cerebellar ataxia due to affection of cerebellar peduncles or cerebellar lobes. Intention tremors may be appear. Sensory level may be occur in spinal cord affection. Loss of vibration and deep sensation may be lost also in deep in posterior column affection. Bladder disturbance. As we know, bladder innervated by autonomic nervous system. Especially regulated by parasympathetic nervous system. The function is to contract the bladder wall and relax sphincter to allow the urine to go out, and normal process of micturition. Demyelination that occur post MS affection may affect lateral and posterior spinal tracts, which disturb sacral reflexes that supply the bladder, mainly S2, S3, S4, result in loss of voluntary or volitional control of micturition. MS sometimes disturbs the central pathway that inhibit the micturition. So, lesion result in elimination of inhibitory pathway, allowing the urine to pass out, leading to overactive bladder or automatic bladder. Inability to store the urine inside the bladder is called incontinence. Loss of coordination between bladder contraction and sphincter relaxation result in dyssynergia between these two types of contractions. In advanced case, result in poor bladder empty, resulting in retention of urine. Disturbance of micturition may be result in. So, bladder dysfunction and disturbance in MS may be occur in one of the following forms. It may be spastic bladder, result in small size, and result in failure to store of urine within the bladder, resulting in incontinence. Or the bladder may be in big in size due to flaccidity, resulting in difficulty to empty as a result of flaccidity and called hypoactive bladder. This synergy between bladder contraction or wall of bladder contraction and relaxation of sphincter result in conflicting of bladder micturition. This explained the failure to store, which is hypercontractile or incontinent bladder, failure to empty or hypocontractile due to weakness of flaccidity, result in inability to void the urine, resulting in retention of urine or combination between them. Incontinence may be present in different forms. Urgent incontinence. The patient wants to void the bladder immediately, urgently, and repeated time. Multi-times need to urgent, immediate evacuate or void the bladder. Stress incontinence occur as a result of increasing intra-abdominal pressure. May be due to distended colon, as in cases of constipation. So, the patient of MS with bladder disturbance must be take laxative to prevent constipation to occur, as it affects the controlling of bladder and process of micturition. Overflow incontinence, over-distended bladder with dyssynergy, lack of coordination between bladder contraction and relaxation of sphincteric muscle. Functional incontinence may be a result from inability to getting to bathroom due to physical impairment or as a result of cognitive affection following the CNS disturbance. This is content woman, bladder is full and inhibit trusser muscle, under voluntary control, she can contract the bladder and bladder walls and relax sphincter muscle to evacuate the urine. But here there is increase in intra-abdominal pressure with disturbance of bladder contraction, result in inability to store the urine inside the bladder, leading to incontinence or involuntary evacuation of urine. Overdistension of bladder may be affected by any disturbance of site of evacuation, may be due to hypoactive petrosal muscle or atonic bladder. If bladder not put in consideration in treatment, it will result in multi-psychological impact in the form of this person will be isolated from the society and she will be depressed. The second common optic neuritis and inflammation of the optic nerves is a common symptoms or forms can be occurred in MS, resulting in disturbance of vision, blurring of vision, or maybe loss of vision of one or two eyes. This accompanied by reducing of visual acuity and visual field. So, visual field examination is required for this patient. Brainstem demyelination may be result in one or more for lesion for the nucleus of cranial nerves that distributed along the brainstem from midbrain bones to medulla. As we know well, the cranial nerve distributed along the brainstem from cranial nerve number 3 to 12. One of these symptoms may be occur as a result of affection. Eye movement may be affected as a result of third, fourth, and sixth cranial nerves. Double vision may be occur. Clumsiness due to incoordination and eighth cranial nerve with its connection with cerebellum and vestibular system. Cranial nerve examination should be affection of the spinal cord depend on which column affected in the white matter, and the symptoms occur according to the affection of tract, whatever the tract, sensory or ascending tract, or motor and descending tract. The patient may be manifested by limbing of one or two leg, numbness and tingling sensation may be occurred as a result of affection of sensory tracts. Urinary symptoms may be appear as a restriction of sacral reflex at S2, 3, 4, increasing of muscle tone as a result of pyramidal tract lesion associated with hypertonicity and positive Babinski sign, Vibration sense and deep sensory loss may be occur as a result of posterior column lesion which carries gracile and cuneate and carries deep sensation to the high center. Neuropathic pain due to the demyelination of spinothalamic tracts with sensory rods maybe results in burning pain. Pain also may occur secondary to spasticity. We know well anxiety and fearing can increase the intensity of pain and affect the reaction to pain. Vertigo. Vertigo is the sense of rotation. Whatever the base of support that the patient stand on it rotate, feeling of rotation, or a surrounding room or areas rotate in front of his eyes. It's different from sense of dizziness. The patient in dizziness feels that he is unstable, while the vertigo is the sense of rotation, whatever the base of standing or the surrounding environment or room. From all of these, MS can be presented by one or more of the following symptoms. May be represented with cognitive dysfunction, swallowing problem, speech affection, visual disturbance, sensory motor affection, balance and coordination disturbance, may be easily fatigue, gait disturbance, vertigo, pain, bowel and bladder dysfunction, in addition to secondary complications that may be occur according to the severity, size of lesion, and the size of the infection. Stages of MS. MS severity ranged from early or mild stage, mild to moderate stage, late and advanced stage. The stage is important in designing the plan of physiotherapy treatment. Who will deal with the MS? As we see in this figure, for treating the MS patient, teamwork should be collaborate with each other to treat this patient. The neurologist, psychologist, urologist, social worker, physical therapist, occupational therapist, psychiatrist, speech therapist. The nurse is adherent to the patient on all stages. Friends, family and volunteers must be cooperated and present in the team of the patient, in the team of the work for treating this patient. Assessment. Assessment includes general appearance, medical history, family history, psychological history, social history, and MS related symptoms. The physical appearance, general mood, emotional status, level of consciousness must put in consideration before starting the assessment procedures. Assessment items should include: assess patient postures if the patient is ambulant and gait, assess the mobility of the joints through range of motion, assessment of balance including static balance and dynamic balance, assess presence of incoordination through assessment of coordination, assess the presence of involuntary movement, assess ADL. Respiratory assessment must put in consideration because weakness and dyssynergia may affect the tolerance and vital capacity of the patient, result in reduced exercise tolerance, which is important for us as a physical therapist. So, assessment of mobility of rib cage, respiratory rate, respiratory rhythm, functional assessment are the important for the patient before applying the exercise program. If the patient is suffering from vertigo, the following items is important to assess and ask it about the vertigo: frequency of occurrence, movement related to the vertigo, the duration of each attack of vertigo, the intensity of attack. The simplest two scales to measure frequency is vertigo intensity scale, and intensity of the vertigo can be measured by using visual analog scale from 0 to 10. 0, there is no vertigo, and 10, the most intolerable. The presence of fatigue in patients with MS is common. So, the assessment of physical therapy or neurological assessment should include assessment of fatigue. We can identify the frequency, duration, severity of fatigue, and activities related to fatigue. Fatigue should be measured or evaluated periodically, maybe every session or periodically every multi or few sessions. Fatigue severity scale is the most simple scale for measuring and evaluating the fatigue. It is about questionnaire, short questionnaire from 9 statements, allow the person to identify his level of fatigue and range it from 1 to 7 points. Stresses, emotional status may affect the fatigue, which in turn reflect on functional activities of his ADL and behavior outcome. Assessment of activities of daily living. There are multi-scales for assessment of ADL. We can choose one of them. But recently, from 90 years, the disability status scale identify the severity of MS. This scale, as we see in this figure, ranged from 0 point to 9 point. 0 point represent in the high column the normal and healthy subject. There is interval between the first from 0 to 1 and 1 to 2, which represent minimal disability. Minimal disability. Minimal disability may not affect greatly the ADL, so the patient may be not come to the doctor or to the physical therapist with complaint of suffering from ADL disability or fatigue. 3. Moderate disability. We can observe that the column of activity reduced. 4. Relatively severe disability. Relatively to what? Relative to number 1. Number 5. Disability affect the routine activities. self-care activities, transfer activities, communication activities, housewife operations, communications. All of these activities may be affected, so we can consider is number 5. Number 6, the patient require assistance, need assistance to transfer, need assistance to carry out the normal ADL activities and self-care activities. Number 7, patient here confirmed or restricted to wheelchair, so he lost part of functions, which is the ambulation or mobility. He can't transfer without using wheelchair, so the part of it is restricted. After that, the patient can't use the wheelchair and become bedridden patient. Bedridden patient means the patient can't use either upper limbs or lower limbs, so he confirmed to the bed. Special tests for MS patient to identify visual fixation, to identify vestibular dysfunction and vertigo manifestation, which is the rotational test, by asking the patient to focus his eyeball on certain subject momentarily, and then the subject or the finger of physical therapist turn it by rotation the head with maintaining fixation of the eye. This performed on slow speed and then graduated to fast speed to identify if the patient have a problem in visual fixation or not. Ramberg test, it is one of special tests which is important to identify sensory ataxia or vestibular affection by studying the semicircular canals. It is illustrated in video. The test will be performed by asking the patient to stand firstly with wide base of support and then graduated to narrow base of support, and observe the posture and the steadiness of his body. The patient then asked to close his eyes. Any swaying observed during eye open and the eye closed. Any disturbance of posture or swaying during closing the eye indicate disturbance of posterior column and proprioception, which means sensory ataxia. However, if the dizziness occurred during opening the eye, this indicated cerebellar dysfunction. Assessment of balance. Assessment of balance may be used scale, may be by observation the patient steadiness during static positions or during changing from position to the other and identify dynamic balance, or maybe use scales, for example Berg balance scale. Computer dynamic posture graphic can be used to identify the degree of steadiness and swaying. Bidex balance system can identify also static and dynamic balance. Balance master also can identify. Balance master can identify the distribution of body weight on both sides, can identify static and dynamic balance, can identify the degree of swaying or the degree of velocity of swaying to each other of the body. Motor assessment including muscle tone to identify disturbance of muscle tone as the pyramidal tract may be affected. Maybe the muscle tone within normal if this is not affected. Maybe hypotonic if it is in the early stage, or maybe spastic due to pyramidal tract lesion, the recovery stage, and this can be tested and identify the intensity and the degree of spasticity by using a modified Ashworth scale. Muscle strength assessment come regularly or secondary to muscle tone assessment. According to the degree of muscle tone, can select the type of muscle testing that can we use. Mild muscle tone hypertonicity or muscle spasticity, mild spasticity, we can use group muscle testing. For moderate spasticity, you can use functional strength test or functional muscle test. Gait assessment can be performed firstly by observation. Observe the patient during enter the examining room, and may be used by simply by 6-meter walk test, or by using video illustration or video analysis through 3-dimensional analysis, and now the most recent 4-dimensional analysis, or by using infrared illustration. According to the available method, we can detect the limitation and distraction or limitation of normal gait from normal parameters. Of course, kinetic and kinematic analysis required. We can use also spatial parameters and select some parameters to identify the disturbance of gait. How to formulate plan of treatment? As we mentioned before, every patient different from the other patient, according to the symptomatic manifestations, according size of lesion, severity of lesion, stage of lesion. So we can put ideal plan of treatment for MS patient. We work or we deal with the symptoms that appear on the patient. Assessment, identify well the plan, identify well the problem of the patient. According to the problem list that we put, we can plan the treatment program. The most difficult case that we can see, it is the progressive type. For patient of MS, we repeat multi-times. Reassessment is required to identify the progression of the disease. It rather than from any types of CNS disease. It requires reassessment periodically to identify maybe the new attack occur to the patient. Generally, MS received drug therapy at the time of attack. The neurologist tried to prevent the progression of the disease as much as possible, and treat the chronic symptoms or residual symptoms from the last attack. Physical therapy program is required. Psychological support is important. MS patient deal with clinic of MS or the life or his life or her life. The clinic of MS should involve all specialists in MS, nurse specialist in MS, consultant or neurologist specialized in MS. Even physiotherapy should be senior neurophysiotherapist, not general physiotherapist for every patient. MS needs social worker. Social worker need social analysis for the patient to identify if the patient need socially for fund, need equipment, need support, social support to help him to carry out his life with support and with his disability. Services, as we said, MS Society. MS Society can, whatever, the Egyptian or International MS Society. Both of them, the patient can follow and cooperate and communicate with patients and with consultant along the net and groups along that can help him in any symptoms, in any job, in any required equipment, in any new attack, and they give information about his nature of disorder. All of this available on MS Society on the net. Again, Egyptian MS Society present in Qasr Al Aini Hospital, Department of Neurology, and they have Facebook MS Society, Egyptian MS Society on the Facebook. So, aims and goals of physiotherapy program different according to the attack. For example, during attack, according to the severity of the case, we can see the MS patient in ICU, so we can follow the ICU program as any patient in ICU, including prevention secondary complication through respiratory exercises or respiratory rehabilitation program, through circulatory programs, through maintaining normal postures during ICU in bed. Relaxation exercises is very important for all stages of the patient. What about if the patient in remission state? Between attack, maybe the patient present with residual symptoms or regaining to his normal life. If the patient present with residual symptoms, we must identify these symptoms, the severity of these symptoms, whatever it is mild, moderate, or severe. And according to the severity, we can identify the program of treatment. In case of no symptoms at all, stress on respiratory functions to help the patient increasing endurance and prepare the patient if there is no new attack come to him, he can has a residual or some oxygenated blood that helping him in regaining the functions through its training. Aerobic exercises is available for improving respiration and general health status. If the patient not in ICU and come to physical therapy or referred to physical therapy, whatever if he is inpatient or outpatient or as a private case, we will play on symptoms management through actual or perfect or advanced assessment. Assessment should be performed in details. First of anything, first of all list of problems, we must put the pain problem in the highest point in the problem list and try to use all killer modalities that we have in physiotherapy. Take care. We can't use heat for improving pain because the subject is sensitive to heat. Can't use hot water. Underwater exercises with heating. We can't use infrared or hot bath. All of this increase and exacerbate the symptoms. So we must select the modality of painkiller according to the nature of the disease. We put some stress on bladder and bowel functions. Try to assess bladder and bowel functions and try to treat them as we will see. Fatigue must be put in consideration during the session, and the period of rest is very important. Hypertonicity, spasticity, or muscle spasm if present, we try to control them. Vestibular disturbance is common in these cases, so we will try as much as possible to reduce the effect of vestibular disturbance and manifestations of vertigo, and we will play on these points. According to the manifestations, for example, if ataxia present, we treat ataxia by coordination exercises, balancing exercises, equilibrium retraining, functional exergaining exercises, and gait training. If the main manifestations that restrict functional outcome and ADL, spasticity, try to control spasticity by meaning of modalities that control muscle tone, or like Bob's technique, or any modality that making tone reductions techniques. Aerobic exercises in all forms of the disease is very important, and we play on from 60 to 75 maximum heart rate for the patient, not increase this range to avoid fatigue. According to the patient's case or status, we can use bicycling, treadmill, walking program, swimming, underwater exercises. From the advantages of aerobic exercises, can increase respiratory functions, circulatory system, and the general health status. Also, aerobic exercises with its graduation and actual period of rest can reduce fatigue in MS. Be sure the exercises performed at sub-maximal level of intensity. Put in your mind, MS patient can't perform maximum exercise. It can lead to adverse effect and leading to fatigue. Physical fatigue results in more exacerbation of the case and weakness of the patient. Relaxation exercises with its variety, whatever general exercises or local exercise. It has multi advantages and aims. It improves breathing, improve fatigue, improve even vertigo. Be sure the site of exercise should be quiet, away from any distraction, comfortable clothes, body positioning. Try to avoid mind from any words by asking the patient to think in happy thoughts. Maybe use light music, maybe use isometric general contraction to reduce effect of stress. Any energy conservation modality related to reduce the overall energy required for every task. Man, if the task is heavy or long for patients, by making assessment, try to make this task and divide this task into subdivision, so the patient performed it in steps, and then after training complete the task as a one unit. This allows successful completion of daily activities. The example here about try to reserve the energy consumption or energy expenditure by using electronics or using modalities that reduce the effect of energy expenditure or energy outcome from the patient. Maybe use motorized scooter, powered wheelchair instead of wheelchair if the patient upper limbs are weak. Try use escalator instead of steps. Maybe use any assistive aid to distribute the body weight and wide base of support during walking, like walkers, crutches, canes. If there is weakness like in quadriceps, maybe use any orthotic to support or lock the knee joint to allow or help him in walking and allow reducing of energy need during activities. As much as possible, try to maintaining the condition or environmental temperature low temperature by using AC, air conditioning. If AC is not available, maybe use fans, neck wraps with cold wraps, spray bottles containing moistening the skin with cooling water. Immersion in cooling water help the patient to be functionally well. Assessment of fatigue is very important again. So, patient with chronic fatigue, allow to him rest activity. The number of exercises or timing equal to the timing of rest. Time of training equal to the time of rest. If the patient need more, allow him to rest until he asked to continue, to prevent the effect of fatigue. Bladder training. Bladder training based on the type of bladder. We can't control or treat bladder disturbance without looking for bowel functions. So, we're treating the bladder through strengthening pelvic floor muscles that carry the bladder and allow help to control micturition process. If the patient suffered from spasticity, we should control spasticity before bladder training. Train the patient how to void the bladder. Assistive aids can be used to maintain the patient socially and psychologically safety by using beds, absorbent bed, to carry the dribbling of urine. If the patient unable to move well and to carry to the bathroom quickly by the effect of incontinence, can use chair and bed beds, and can use a dribbling pouch. All of this helps the patient psychologically to be self-confident and prevent the effect of bladder disturbance from to be the patient isolated. Physical therapist and neurologist and urologist and nutritional therapy cooperate together to treat the incontinence problem. Why? This incontinence problem may be result in skin breaking down and urinary tract infection. Both of them are fatal to the patient, and sometimes they lead to social isolation. The patient be restricted his activities and to be away from the community by reducing his functions and depression. So it is important in the medical field to treat bladder disturbance. Bladder disturbance treated by behavioral therapy techniques by changing lifestyle. So, nutritional therapists play important role by scheduling the fluid and dietary medications. The nutritional therapist put the volume of fluids and the nature of fluids. The fluid made by scheduling for the patient. يشرب قد إيه؟ كمية قد إيه؟ Some fluids are inhibited, which is diuretics fluids like caffeine, tea, أي عصاير تخلي إن البيشنز إن اليورين يكون كميته أكتر ويكون سريع إن هو يروح يبقى محتاج إن هو ميكتيوريت. وطبعا البيشنت مش هيقدر إن هو يروح على الباثروم بسرعة، فبالتالي هتسبب لي مشكلة سايكولوجيكالي ومشكلة في البلادر تريننج. Constipation must be prevented. So every patient with MS should receive daily glycerin suppository for prevention of constipation. Sometimes the doctor gives him laxative drugs. Bladder training include educate the patient how to void. Started gradually according to the schedule of fluid intake. ياخد الفلويد ask him after ربع ساعة يبتدي يتوجه للباثروم. بعد كده هبتدي gradually أزيد فترة التايمينج عشان أقدر إن أنا يقدر يعمل controlling لليورين أو store the urine inside the bladder. During this time لازم أكون بعمل training للبلفيك فلور muscles. لازم أكون اتأكدت إن البلفيك فلور muscles carry the bladder عشان تقدر تكمبنسيت disturbance action of the bladder. Constipation prevented. Body weight reduction very important. If the patient thin, prevent him from any diet that allow him to be fatty. Smoking should be prevented or stopped. For good bladder habits, fluid intake is very important. Good toilet habit according to the scheduling that designed by physical therapist and nutrition therapist. Maintain good bowel habits to prevent any constipation, to prevent any intra-abdominal pressures that increase on the bladder, result in pushing or allowing easy get rid of urine. Exercising for pelvic floor muscles. All of us know well pelvic floor exercises, which is named Kegel exercises. The patient is lying in crook line. Allow the patient firstly to relax by deep inspiration, isometric exercises generally, and take deep breathing. Then ask the patient to squeeze pelvic floor muscles. Help him by asking her to squeeze muscles around the anus, gluteus maximus, hip adductors, and the lower abdominal muscles. Maximally for 10 seconds, and then relax. Relax also for 10 seconds, and then repeat again the contraction. Firstly, try to contract muscles around pelvic floor, muscles around anus, adductor muscle, then gradually increase by abdominal muscles. Physical therapist and occupational therapist play a role after that in bladder dysfunction retraining. Allow the patients the toilet bathroom well from any accessories, from toilet chair, to help the patient to be the patient to be easy to evacuate. Catheterization if needed. It is preferable to use intermittent catheterization to avoid infection. Feedback may be used like mirroring, like hearing the sound of water. Patient may use his hands to push and complete evacuation by pushing above supraspinal pubis, in and down. Patient may help himself by tapping on upper adductor side of the thigh. May scratch the hair on the supraspinal symphysis pubis. Bowel assessment should be performed parallel with the incontinence, Constipation should be stopped immediately by any method. Incontinence evaluated by its onset, frequency, and duration. So the doctor can help or physician can treat constipation and bowel and urine at the same time. Vestibular rehabilitation therapy, VRT, the series of exercises based on programs designed to promote vestibular adaptation and substitution. So it is provoked exercises. The goals of these exercises: enhance gas stability, which is important for ADL. Allow and help in eye-hand contact. We can't picking up any object or manipulate any object by hands without eye contact and without proximal stability. So postural stability, static and dynamic, is very important and complete the action of gas stability for completing the action of ADL. Vestibular rehabilitation treatment or programs inhibit and reduce as much as possible the effect of vertigo, which allow the patient to be restricted from ADL. Vertigo manifestations, it is most commonly associated with autonomic manifestation, like feeling of nausea, feeling of blurring vision. The patient may be vomit at the attack of vertigo. Improving of vestibular visual-vestibular interaction, reduce the effect of anxiety and stresses that may be occur from the effect of vertigo. So the results of all of these aims decrease the risk of falling and increase the ability and the levels of activities of daily living. Physiology of vestibular rehabilitation program based on adaptation for visual vestibular interaction, which allow possibility of eye-hand coordination by using repetitive and provocative movement of head and or eyes. The second theory is substitution by the use of single or combination of sensory input and like eye movement system by using vision and somatosensory tools. Postural strategies which are based on motor learning processes. Adaptation and substitution based on repeated head movement to promote habituation to feeling of dizziness. Positioning maneuver to prevent the onset of vertigo. Exercises to improve eye-head movements, coordination, fixation of gaze, and balance retraining. The frequency and duration of the exercises, it may be take from 4 to 8 weeks. Physical therapists and occupational therapists can apply them. According to the case, may need more 1 or 2 weeks according to the severity. Also, the session may be performed daily or weekly, 1 or 2 per week, 1 or 2 sessions per week. Home program is very important, which is progressive, and the physical therapists give figures and exercises, written exercises by schedule to the patient and help him to apply in house, and they can follow him with telephone. Vestibular exercises protocol started with little difficult position, so started with gaze instability. Gaze exercises can facilitate vestibular visual interaction, as in cases of unilateral lesion, can facilitate cervico-ocular reflex through head movement of the body to relieve of the body relative to the head. This is in case of bilateral loss. The first exercise is habituation exercise. This can be illustrated in video. I advise you to show it. You will enjoy and try to repeat on yourself or any colleagues. Habituation exercises aim to reduce the effect of sensory stimulation through repetitive exposure to provoking movement. يعني بنعمل الموفمنت اللي هي بتؤدي للفيرتيجو and let the patient in it and then regain to the starting position. Gaze stabilization exercises by fixating the eye on a movable object while turning the head. This turning may be transferred from side to side, from right to the left, or from up to down. The position of the patient, firstly from sitting and then graduated to standing, and after that during walking. Gaze stabilization reduces motion induced by disequilibrium and help to fix the retina and release the effect of gaze instability. As we see in these figures, firstly, the patient look the subject. He can train himself by fixation the subject and turn the head right and left. The opposite may occur. Instead of fixation the subject, move the subject right or left with turning the head right to the left or up to down. Severity of exercises may be increased by distracting the background of the paper by using light or distracted figure like this. But take care, this contraindicated for patients suffering from stigmatism. He will feel dizzy. Third exercises is Cawthorne-Coxey exercises. Cawthorne-Coxey exercises use the activities of head and graduated to upper limbs and body as a whole. Firstly, use eye with the head, looking eye up, connected with movement extension of the head. For example, eyes looking down is connected with head flexion. Then graduated to trunk, upper limbs, and activities by using upper limbs in activities like throwing a ball and during walking. Co-thorn exercises modified by adding 2 exercises to each other. Co-thorn exercise and gas stabilization exercise. Gas stabilization exercises with moving the hip and moving upper limbs and moving the body as a whole, and this is graduated along the day, and you can perform it from 4 to 5 times daily for a total about 20 to 40 minutes per day. 20 exercises may be added to gas stability and co-thorn exercise in the form of balance training, static and dynamic balance training, and gait exercises or gait training. Alternative medical treatment or alternative modalities for reducing the effect of vertigo based on relaxation techniques like Tai Chi and yoga, which is helpful in reducing effect of anxiety and symptoms of vertigo and denseness, and the effect of these two dysfunction on balance result in imbalance by using Tai Chi and yoga techniques. Certain postures and gentle movement with mental focusing on something, with deep breathing exercises, all of them leading to relaxation, and you can perform from and graduate from different positions, from sitting, standing, and walking. Conclusion of the effect of MS and studying the MS, we can conclude that most of patients suffering from bladder symptoms, so we must put it in consideration. Symptoms of patient vary from patient to another, so treatment modalities should be based on symptoms of the patient. Sometimes we need the patient in the remission state, so we play on the residual symptoms and we act on them to treat them. Most of patients and symptoms of patients have impact on quality of life, so periodic assessment of the patient functionally is required. Regular functional assessment and assess quality of life for this patient is very important. Evaluation related to job is very important, which is mainly the role of occupational therapist. So we deal as a teamwork for this patient. Multiple treatment modalities available for MS cases. Can treat spasticity only, I can treat bladder disturbance only, I can treat the vertigo manifestation according to the case. So treat the patient according to the symptoms appear. Thank you for paying attention.